Ora prenderà la parola il professor Joel David Cooper, che terrà la sua Lectio Magistralis.
Chancellor Pelkani, Professor Moranti, President Tomasi, my good friend Professor Fabri, who I believe instigated this in the first place. It is an enormous honor and privilege, and I'm very overwhelmed by your presence and by your honor. I thank you very, very much. I cannot think of a greater honor that I have ever received, and I appreciate it very, very much. I'm pleased to be able to give a short presentation today. And I wanted to share with you some reflections on our particular careers in medicine and surgery, of the opportunities that have been made available to all of us, and as a result, our obligation to our profession, to our predecessors, to our society, and to our successors. My message is a simple one. It is an enormous privilege to be a physician at this point in history. We have a very proud heritage. We are standing on the shoulders of giants. We have today at our disposal unprecedented resources which empower us as physicians as never before to perform miracles for our patients. And we are obliged and obligated to inspire and to encourage our successors. We live in a very exciting time in terms of medicine. We are entering a new and exciting era, building on advances in molecular and cellular biology, the elucidation of the human genome, and science fiction-like developments in technology that were just unimaginable even 20 years ago. One doesn't have to be prophetic. You only need to look backwards at our progress to see how exciting our future is. But part of our profession is our ignorance, the anguish that the physician suffers whenever there is an adverse outcome, for the frustration of the diseases and the conditions that we cannot control, for our vulnerability, our imperfections, for the questions we are unable to answer, for the secrets not yet revealed, and for the knowledge not yet acquired. And those should prompt us all to work diligently to try to find those answers. I want to take just a few moments to share with you some of the clinical milestones that I have been privileged to participate in. They are examples of how basic research and clinical research on the part of an entire faculty can come together to impact the lives of the patients we treat. In 1963, after years of laboratory research, Dr. James Hardy at the University of Mississippi attempted the world's first successful lung transplant. The patient died 18 days later. But nonetheless, this experienced kindled excitement and anticipation around the world. As shown in this chronology, over the next 20 years, approximately 38 lung transplants were attempted without any success. The one done in 1978 by our group in Toronto was also unsuccessful and led us to review the experience around the world of lung transplantation. Our patient died when one of the technical connections between the donor lung and the recipient failed to heal properly and was the cause of death. When we reviewed these patients, we found that only 9 of those patients lived as long as 14 days. And everyone that lived beyond 14 days died because of or with that same problem that our patient had. And so, bronchial dehiscence, the failure to heal one of the connections, the airway connection, appeared to be the Achilles heel of transplantation. It was widely believed that perhaps this was inevitable. Perhaps this was a manifestation of rejection. Perhaps it was not possible to transplant human lungs. On performing the postmortem examination of our patient in 1978, and I was trained as a resident that when a patient of yours succumbs, it is your obligation to perform the postmortem examination in order to learn as much as you can. And it was a chance observation during that, particularly that the healing process in general in that patient did not seem ordinary. It seemed impaired. I think it was Pasteur who said in the fields of experimental observation, chance favors the mind that is prepared. Someone observed that chance also favors the unprepared mind. So we undertook experiments in the laboratory to see what it was that we might correct. What we did, using an animal model, a dog model, was to remove the lung and to put the same lung back into the same dog, performing all of the technical aspects of a transplant, severing and reconnecting the pulmonary artery, the pulmonary veins, and the bronchus, the airway connection. Half of the animals, we gave drugs to prevent rejection in the same doses that we would give in the case of a clinical transplant. Of course, the animal did not need the drugs because there was no possibility of rejection. It was its own blood. And the other half of the animals, we did not give the immunosuppression. And we found, as we suspected, that the animals which received the drugs failed to heal the bronchus. And the animals which did not receive the drugs did not fail to heal. They did heal the bronchus. And so we showed that it was not an immunologic event. It was not a rejection event. It had to do with various factors, including blood supply and the type of drugs that were being used. At any rate, without going into further details, based upon several years of laboratory investigation, this gentleman was able to undergo in 1983 the first successful lung transplant. He is shown here about a month afterwards, still looking quite feeble as a result of the chronic pulmonary disability that he had had before his transplant, but no longer requiring oxygen. 3 months later, when he returned to full employment, he had regained his health and his vigor. He and I would often share the podium when trying to raise awareness for the importance of organ donation and support of research. And when we were together, he always correctly observed that the healthy-looking one of the two of us was the patient. 5 years later, we had a seminar in Paris to try to disseminate our experience. Mr. Hall, our patient, came over to speak to the participants. He said how wonderful it was to be in Paris 5 years later, to be able to see the sights. However, he said the real test of his transplant was the evening before, when he went to the Lido. He said, I was panting with the best of them. We chose one disease at a time to transplant and tried to develop a systematic program. This young woman suffered from a condition called pulmonary hypertension, mostly in young women, a narrowing of the blood vessels in the lung, which in turn makes it impossible for the heart to pump the blood through the narrowed vessels. Pulmonary hypertension. There was an experimental drug that she was on, and it would have been a cost of $1 million a year. It did not cost that because it was supplied by the pharmaceutical company. And on her birthday, January the 26th, 12 years ago, she underwent a lung transplant. She still goes skiing in the mountains of Colorado. She probably had about 2 months to live at the time of her transplant. And when I recently called her on her both anniversary and birthday being the same day, she was once again skiing in the mountains of Colorado. Those transplants involve a single lung. One good lung is all you need. But we were very eager to transplant patients with other conditions, emphysema, and the condition cystic fibrosis. For reasons I won't go into, it was felt that replacement of both lungs was necessary. And we developed a model for replacing both lungs using a primate, a cynomolgus monkey. This is Hercules. He was our first success. And this woman, who had severe emphysema, was our first clinical patient. In November of 1986, she underwent a bilateral lung transplant. There she was 5 years later. The first 3 individuals to undergo the bilateral transplant November of 86, January 9th of 87, February 23rd of 87, were shown here after their transplant and became very good friends. 13 years later, we had a little celebration. Kathy was on oxygen, had rejection, and died at 14 years. Doris is 19 years and goes to work every day. And Anne unfortunately passed away about 15 years later of unrelated causes. We were very excited to be able to transplant a condition called cystic fibrosis, a genetic deficiency which causes increased secretions and infection in the lungs. In my day, when I was in medical school, the average survival was 8 years. Now, thanks to improved care, half of these patients survive over the age of 28, but nonetheless generally die of infection. He was the first. We did him in 1988, and so he is now approaching 18 years and works regularly. His wife had a transplant also for cystic fibrosis several years later. I once heard someone define a miracle as an event that leaves you with an abiding sense of astonishment. No matter how often you recall or speak of the event, you always are amazed. You shake your head in wonderment. This man was on a ventilator, dying of end-stage lung disease about 14 years ago. For the next 12 years, after his bilateral lung transplant, he would go to a trip to Switzerland, and he sent me this photograph. This was 8 years after his transplant. Every time I see that picture, I think I'm seeing a miracle. Our experience with lung transplantation, many of which are for patients with emphysema, led us into exploring other possibilities for the surgical treatment of emphysema. And based on observations that we made in the lung transplant program, and based upon observations made in the late 1950s by a Dr. Otto Brannigan, we embarked on a new operation called lung volume reduction surgery. Basically, it is to remove the most diseased portions of the emphysema lung to allow the remaining portions to breathe more easily. It is not a cure, it is a palliation, but it can restore the quality of life. This woman was on a respirator in bed. It took 2 people to lift her into her chair, which was the only activity, and arrangements were made for her to go to a terminal care facility. Her family, however, heard about the emphysema operation, arranged for her to come to our institution. It took us 3 months of rehabilitation to get her off of the ventilator, after which we performed the operation, and she sent me this photograph 1 year after her operation. 5 years later, knowing that I loved to go fishing but never had the time to do it, she taunted me with this photograph. This man had lung function 12% of normal, shown before and after the volume reduction procedure. Struggling for breath and on oxygen beforehand. He is breathing. We did not tell him, hold your breath. But it looks like he's not, because the effort is so much less. He really needed a transplant, but he would not live long enough for a donor, so we first did the volume reduction. In fact, he did very well. And for the next 4 years, returned to his farming activities in Texas. Again, shows the overinflated chest, and 6 months later, after volume reduction. 4 years later, he had deteriorated, and he then had a lung transplant. I asked him, send me a little video so I can include it with the video. He sent me an hour-and-a-half video, 45 minutes. He didn't talk to the camera, just 30 minutes of this, and 20 minutes of that. I said to him, Paul, I'm only going to use a few seconds. Why did you send me an hour-and-a-half? He said, I wanted to show you what I could do. So this man today is alive and well. He is the same man you saw sitting in the chair there in 1993 or 1994. I want to emphasize that the patients I have shown you, the lung transplant patients, the volume reduction patients, these are not surgical triumphs. They are medical triumphs. They are triumphs of science. They are a result of a dedicated team of many disciplines, medical and otherwise, anesthesia, pulmonary physicians, nephrologists, hematologists, pathologists, radiologists, physiotherapists, nurses. A team that make up the individuals necessary to accomplish these feats. In closing, I just want to emphasize our responsibilities. We must appreciate our heritage, the privilege and the responsibility that we have. We must bring honor to our profession, comfort to our patients, pride to our supportive families, and prepare for tomorrow's opportunities. We must respect our traditions and the great accomplishments of our predecessors. We must maintain the highest standards of ethical and moral behavior and avoid the temptation of putting our own self-interest ahead of that of our patients and our profession. We do have legitimate self-interest as a profession and as individuals. And I believe that this self-interest will be furthered the most by unselfish devotion to others. To the modern tools of our profession, we must incorporate the tried and true instruments of our heritage: compassion, commitment, discipline, self-sacrifice, and always the pursuit of excellence. One of Sir Winston Churchill's forebears was allegedly once chided for the lack of distinguished lineage. He was a commoner. He responded, I may not be a descendant, but I will be an ancestor. We here today are privileged to be descendants. Descendants and beneficiaries of a long and proud and distinguished academic tradition. At this institution, I believe it dates more than 800 years. So how much more then do we, as beneficiaries and descendants, have an obligation to be ancestors, to encourage our successors, to attract and motivate and mentor the next generation. We must always remember as physicians that our true foe is ignorance, disease, disability, and human suffering, and that bringing comfort to our patients and pride to our profession must be the focus of our efforts. Thank you so very much for bestowing upon me this great honor.